And I want to welcome, turn that camera around to the doctor in the studio. Oh, and Kevin Kerrigan's on the welcome back to television, Kevin. Dr. Is it Sekhar?
Yeah, Sekhar.
Dr. Sekhar, who is an interventional cardiologist with the Guam Regional Medical City, brand new to Guam, yes?
Yeah, I've just been here on island for a couple of weeks now.
A couple of weeks. Well, welcome. And I'm sorry for anything that it was a bad experience so far, maybe the weather or something, but
no,
everything.
It's been great. It's like it's almost like what they say. It's a tropical paradise.
Yeah. Well, it's hard. It's hard to go wrong with the tropical. Last you came from New Jersey, right? So, so we look really good compared to New Jersey.
Definitely.
Yeah. So you've spent a lot of time on the mainland, of course, getting training and then in practice.
Yeah. Actually, I was in different parts of the mainland even during my training. So it's like initially I was in Rhode Island and then moved to Utah, Salt Lake City.
Yeah.
And it was really beautiful there with the mountains. And, and then moved to Kentucky and New Jersey. So for all different parts of my training. So it has been like having seen all these places, I can say that it's like Guam by far is like the most.
It's a little culture shock, though.
Yeah.
Where are you from originally?
From India.
Okay, what part of India are you from?
In the south, there's a city called Bangalore, and that's where I was born. And actually, it's funny. Like for the initial, I went to even medical school there, and until the initial part of my life, I was just very frustrated that I could never travel out, and I was like, I always wanted to explore the world. And then it's like once I was done with my medical school, I actually went to Germany for a PhD for research. So and then moved to the US for the like the final part of the.
So is the education all transferable? All of that education and training that you received is recognized and transferable to the United States?
So basically, for the medical, it sort of depends on what part of the education. So for medical education, so the medical schools have to be recognized internationally. There's like each medical school has to be recognized, and then there's a separate body that called ECFMG that does that recognition. And if you have completed medical school in outside of the US, so you have to provide the certificates for that, and then you have to give the what's called the USMLE exams. So these are the same exams that are given by the medical students in the US.
Oh, so you passed it with flying colors. There's no problem. Yeah.
So and then the other part is that so to practice in the US, you have to do your residency training. So the USMLE is sort of like the exam to qualify to do residency training in the US.
Yeah.
And
so was your specialty always this? Was it also always cardiology, or was that did you come across that as something else?
So basically, cardiology is what's called a subspecialty of internal medicine. So internal medicine is the doctor who you see when you go to check your blood pressure. The internists take care of blood pressure, diabetes, and the normal what used to be called as the family doctor. And the difference between really a family practitioner and a true internist is that the family practitioner also can see pediatrics, and they also do some OB-GYN, whereas internists focus mostly on just the medical problems. And there's also one part of the internists also work in the hospital, and they are called hospitalists. And so you have to do 3 years training in internal medicine, and before you can do subspecialty training. So the subspecialties within medicine would be like things like cardiology, dealing with the heart. It would be things like endocrinology, dealing with the things like diabetes, kidney disease, that would be nephrology. So all these different specialities within internal medicine. So after that, I did my training in cardiology, and even during my medicine training, I knew that that's what sort of fascinated me the most. It's,
really? What was the fascination with cardiology? Just out of curiosity.
So it's a couple of different things. So it's from just actually also a personal point of view. My father also has heart disease, but he was actually diagnosed a little bit later when I was doing my training. But it's also like a couple of different aspects. Cardiology is one of the branches which has actually sort of dramatically changed over the last 30 to 40 years. So compared to say in the 70s and 80s, what we were able to do for patients with heart disease was mostly, you could just give them an aspirin and have them try to rest, and you would just hope that they did better.
Yeah.
And heart disease, even at that time was the number one cause of death, and even now sort of 1 in 4 deaths roughly in the US is due to heart disease. But we have made some actually dramatic progress in terms of the
interventions.
Also interventions, and also it's actually starting to even decline.
To decline, right?
And at some point, it looks like cancers will probably be the number one cause of death. So in terms of like what you mentioned, the interventions, that is again dramatically changed. So you not only have like very effective medications now. We also have things like stents to open blockages out, and these can be done what's called as percutaneously. Basically, just do through not even an incision, just a small needle stick. And
that's amazing to me, because you think about the numbers of people who have died over the years without that technology, without that great discovery.
That's your specialty.
Yeah, and that's your specialty. And the procedure. I have a friend who's 50s, and usually I'm very good. In fact, a doctor, and in great shape. Found out that there was something wrong with him. He didn't even know. And just felt funny, went to the doctor, and they put a stent in, and that was it. And it was done. And now just that knowledge that he had, that it was such a simple procedure and it was out the door in no time, makes a huge difference in a person's life.
Yeah, it's also interesting. Even within these kind of interventions, there are broadly you can classify into 2 types. One is sort of more stable patients, meaning that they were having some symptoms. And right now, for those patients, actually, there are a lot of options. Even the medical therapy has actually gotten very good, and it's sort of, the main reason for like having an intervention like a stent would be more symptom relief in those patients where, they are not being able to tolerate the medications because of side effects, or they are not getting enough. Is
it a choice, a patient's choice? Or is it your recommendation?
So it depends. So for patients with stable disease, what's called a stable angina, meaning that they know their limitations. If they walk, say, half a block, they get chest pain and they rest, and it goes away. And it's been that way for years. That's what's called as a more stable angina. For those kind of patients, we always prefer to try medications first. And only if medications, like I said, they're not able to tolerate it, then you would consider more other additional interventions. And there's actually now data showing that stents might be better for like symptom relief, but in terms of long-term mortality, that basically the number of patients who survive longer, it doesn't make a difference. But that's for stable patients. For patients who are actually having a heart attack, there I think that's where the majority of the benefit with interventions such as stenting has really made a big difference. Is for unstable patients, you are able to do what's called as a acute revascularization for a condition known as ST elevation MI, which is in common parlance like a patient having a massive heart attack. And in these patients, the blood vessel is blocked. And so it's sort of a race against time to get the blood vessel open as quickly as possible, because if the blood vessel stays blocked for too long, that part of the heart muscle basically dies. And so the goal, for example, in the mainland US is to try to get that in a patient who is having that kind of a heart attack, to have the blood vessel opened within 90 minutes. That's the goal. Because that it has been shown that earlier you get the blood vessel opened, the better the outcomes are.
Wow. Do you have the capability of doing that here at GRMC?
Ideally, we're going to have that available sometime next year. It takes a couple of things to get that set up. One is actually not just these procedures are done in what's known as a cardiac catheterization lab. The procedure itself is called as cardiac catheterization with percutaneous intervention. That's the like the jargon for putting in tubes to take pictures of the blood vessel supplying the heart and look for which vessel is blocked, and then to fix it with putting a stent in. So we need to have that available. We also, the US guidelines suggest always having a cardiothoracic surgeon available as a backup. In case we are not successful, the other option would be open heart surgery and trying to get the closed vessel bypassed.
Enter Dr. Noah Concepcion.
Yeah, exactly.
Yeah.
So he is going to be on island next month, and it's going to take a couple of months for him to get everything set up. So by the end of the year, we are expecting that we will do bypass surgery, and during that period, we will start doing some cardiac catheterizations, and hopefully sometime next year, we will be able to do what's called as primary PCI, meaning that for patients with having heart attacks, that we would be able to treat them with the goal of trying to get the blood vessel open as quickly as possible.
I'm wondering what the difference is for you personally, coming from a place and all of the hospitals where you worked at, where a team was already in place as you would need it to treat patients, and then coming to Guam, to GRMC, a brand new hospital, brand new facility, starting from the bottom and working their way into what will be this incredible service for in cardiology. Which is more satisfying, coming in and helping to form a team and being part of a new team, or being in an established sort of place? I'm wondering what the appeal is.
I think it's sort of, at least for me, it was a very conscious choice that, when I heard about this opportunity, it was very exciting. Like for, I think a lot of, actually, if you talk to my other physician colleagues who decided to move from the mainland here, that's what is sort of really exciting, is that on the mainland, sometimes in like a big hospital, you are sort of one among the 15 cardiologists. Sometimes you feel like you are just a cog in the wheel, and so if you are not available, there's always somebody who can easily replace you. And here, on the other hand, it's the excitement is also being able to build something from scratch, and the need is huge. And so it's also very personally satisfying to be able to provide a service which is sort of very needed in the community, and which will hopefully make a big difference to the community, because right now the options are not really great for these patients who have heart attacks on the island. We can treat them with medications, but some of these patients are not able to have the medications because of some specific other conditions that they have, and so these and the
so they need a procedure. They need an actual procedure.
And the medications are also not as effective as stenting sort of during a heart attack. And it's not really a great option for these patients to go off island, because they are having a heart attack. They are not even stable enough to get on a plane and to be even flown out. So I think that's what is sort of the appeal here, is that to help set up this kind of a facility, it will provide really a service which is it cannot be replaced. It's not like that's where I was drawing the distinction between a stable patient and an unstable patient. A stable patient could potentially go off island, get their problems fixed and come back, whereas for patients who are unstable, who are having a heart attack, this is not really an option. They cannot even usually travel for a it's not even safe for them to get on a flight for a few weeks after the heart attack, and by that time usually whatever damage is done is already
it's already there.
Occurred.
How can I start from the beginning on something very basic about what a person knows about their condition? How do they know? You have perfectly seemingly healthy people, great diets, exercise regimen, and die of heart attacks. And die or heart disease, and without really even knowing there was anything there. You think that the patients largely ignore some of these symptoms?
Yeah, there's sort of majority of these so-called silent heart attacks. There is some of them have diabetes, and you have to sort of split them into those two categories. Those who have diabetes, unfortunately, can develop a condition called neuropathy, where the diabetes affects the nerves, and so they don't sense the pain, and so sometimes their disease can progress and they might not sense that they have had a heart attack. But in the other half of the patients, so those who have had heart disease, they tend to one of the common misconceptions is that you have chest pain. So most people don't really feel pain, they feel more like a squeezing or a tightness in the chest, and so it's more like chest pressure, and feeling like some people describe it like a ache or a weight on the chest. And so a lot of, especially typically men are at higher risk as they get into their 50s and 60s of developing heart disease. And so sometimes men sort of also tend to also try to shrug it off. It's part of it is, I think, a little bit of denial. They don't want to even think about it, and it's like and the other half is also trying to say that it's like, no, there's nothing wrong with me, and they try to go on with whatever that
as long as they're not feeling it, that they
exactly.
can feel it. Yeah.
And the other thing, especially on an island like this, is that they might apparently be healthy, but because of just how difficult it is to get good medical care here, it's also been a challenge, I think, to do what's called as prevention. So going annually to get your blood pressure checked, make sure that you don't have high blood pressure, you don't have diabetes, you don't have high cholesterol. All these conditions increase the risk of having heart disease, and if you have all three, then that it dramatically increases the risk of having heart disease. So and with most often what happens is that patients have not seen doctors for years, and it's the same. It's like, if you're not the problem with things like diabetes or high blood pressure is that you will not feel anything with those conditions, but if they have been there for a long period of time, they have been affecting the blood vessels supplying the heart, and by the time you already start to develop problems with your heart, you start to have some chest tightness, you continue to ignore it and try to go on with what you're doing, and a lot of them also have things to do. It's like most of these people are like actively working in their 50s and 60s, and so they try to put it off, and at some point then it sort of catches up, and ideally we'd want to try to treat these things in the preventive side. We don't want to try to fix every patient with heart disease with a stent. That's not the goal. The goal would be to try to actually so the way I see my services is sort of like like trying to put out a fire. So you don't want to be putting out fires all the time. You want to try to prevent the majority of the fires, and the ones that are happening you want to try to put out. So that would be the overall goal, and that's where I think the cardiology team that we have, Dr. Holland, one of
I was going to ask you, if you don't mind, I'm sorry to interrupt you, but Dr. Holland is a cardiologist, and you're partnered with her. What makes your jobs different?
So to sort of like a simple way of trying to think about it is that the heart has different components to it. So one part of the heart has blood vessels supplying the muscle of the heart itself, and so my specialty is actually to try to deal with the blockages in the blood vessels and try to open out those blockages if we need to with stents. And so some people used to call the interventional cardiologist as the plumber of the heart. So you're trying to just open out the blood vessels. So Dr. Holland, her specialty is dealing with irregular heart rhythms, and so her specialty is she's sort of like the electrician of the heart. So if there are like simple plumbing jobs, then I can try to get that done. But if there is a major blockage, then you would have to call somebody like Dr. Concepcion, who practices in cardiothoracic surgery, so that is open heart surgery. And so for major blockages, if you have multiple blockages, or if you are diabetic, there is data showing that bypass surgery is better if you have multiple blockages. So
you mentioned something about high blood pressure. That's a great indicator of something that might be wrong or something to keep an eye on. I understand that there's a new study with new recommendations about the numbers on blood pressure.
Actually, the full study is not yet out, but it was so dramatic that they sort of had to what this study.
They want to make sure that it's correct.
No, actually,
okay.
it's been very controversial. What should be the blood pressure goal for patients with high blood pressure? So how low should we bring the blood pressure? And so what this study was trying to do was to look at the what's called the systolic blood pressure, the upper number when you check your blood pressure. And so normally the standard guideline that was published last year was that you have to try to get the blood pressure lower than 140. So this study interestingly compared patients whose blood pressure was brought down with a goal of 140 to those whose goal was brought down all the way to 120. That was, and people used to think that if you try to bring it all the way down to 120, you might get a lot of side effects from medications. Patients might not really do that well. And so, whereas the other, there is a lot of data that also seem to suggest that the lower the blood pressure is, the better it is. And so, because of there was this conflicting data, they did a study where they put half of the patients with this as the goal, the other half with the higher goal. And they were actually planning that it would take them around until 2016 or 2017 until they would actually have the full results, because they thought to see a difference would take that long. But it already in 2015 they started to see that there was a dramatic difference in the two groups, with the lower blood pressure group having much better outcomes. So they were able to already notice that the lower blood pressure group had like a lower incidence of heart attacks, and also this overall even just death. So it was a very clear difference, and that's why actually they had to even stop the study in between and say that it's not ethical to continue with the study because there are more patients dying, significantly more patients dying in one group.
So that hasn't made the mainstream media yet. That's not necessarily been released.
The initial they actually came out with a press release saying that this has shown a big difference, but the full study where they have to look at every single details of the things. So, for example, which group seemed to benefit more? Where was that patients with diabetes? Where the older patients, younger patients?
Right.
Was there a difference in what type of medications they were treated on? And what's interesting about this study is that these were all treated with generic medications. So these are actually very low cost medications that are already available, and so this can actually have a dramatic difference on way generally blood pressure is treated for all internists. And there are, like, just to give you an idea of the magnitude, so there are around 80 million patients in the US with high blood pressure, and so 2/3 of adults over the age of 60 in the US have high blood pressure. This is something that can help to reduce the risk of death in 2/3 of the adults. It's like that's a big this thing. So that's why they're already went up with the release, and it will probably be a few months before the full study is out. Already the American Heart Association has indicated that this will affect the guidelines, but the full study the guidelines will be released after
well,
that.
When that comes out, we'll have you come in and explain it to us so that the layperson can understand. We're short on time. We've just blown through a whole half an hour with you. I appreciate that. Thank you, Kevin. I appreciate you bringing him in. I am looking forward to having Dr. Holland in here again. She's a great gal. And even Dr. Noah Conception when he gets here. That's going to be a treat for all of us. Thank you so much, Doc. We appreciate your time.
Thanks, Patti.